Welcome to the Eat, Play, Love Holiday Edition. I'm Sandra Leah, Director of Education and Patient Advocacy at Obesity Matters. Please meet my co-host, Rachel Atkins.
Hi, everyone. My name is Rachel Atkins. I am the Director of Strategy at Obesity Matters.
Obesity Matters is a nonprofit organization for people living with elevated weight and obesity. It was formed by patient advocates whose focus is to provide evidence-based education and advocate for public policy and environmental changes that enable well-being. And if we can do that, we are one step closer to the acceptance and inclusion of millions of people in larger bodies. The Eat, Play, Love Holiday Edition runs weekly interactive events with experts and patient advocates. The first half of the episode is the interview. And then we turn the spotlight onto the audience, you, to address your questions and comments in a safe and supportive environment. This season, we're focusing on reframing how you celebrate the holidays and approach it with positivity. We are adding a holiday theme to each episode. So for today, we'd like you to show us your holiday accessory, whether it's a hat, a scarf. I have my pin, I have my penguin earrings. I don't need much of an excuse. So let's see what everybody's got. Rachel, you've got on a beautiful scarf.
Yeah, it's from Ireland, from a trip that my mom and I made. So I love the scarf and it's so warm.
Oh, of course, Ireland. They know how to stay warm there. Today, our special guest is Dr. Anil Maheshwari. I hope I said that correctly. He is an executive health physician and medical director of weight and lifestyle management program at Cleveland Clinic, Canada. Anil, thank you for offering your time today. Before we start diving into the questions, please introduce yourself and tell us your areas of focus in obesity medicine.
Okay, well, thank you, Sandra and Rachel, for having me. And hello to everyone. My accessory is actually an ornament off of my tree because I don't have any kind of earrings. So I'm a weight loss physician. I've been practicing as a family doc for 20 years, but I'm a weight loss physician for the last, I received my, or achieved my ABOM status. So that's the American Board of Obesity Medicine earlier this year. And in Cleveland Clinic, Canada, we have a comprehensive program with like psychologists, exercise physiologists, dietitians, and myself. And then I'm also working out of a family health team in Cambridge, Ontario, and helping with the patients there.
Wonderful. So let's get right into it. What makes obesity a chronic disease and not a lifestyle issue or a lifestyle choice, as many of us have been made to believe through the years?
Yeah, that's a great question. And that's one that slowly I feel like perceptions are changing. But yeah, most people do feel like if I could just work harder, if I could exercise more and eat less, I know I could lose this weight. But the reality is that most of the time, a lot of diets lead to weight loss and then weight regain. And obesity is much more complex than just increasing exercise and eating less. I mean, there's genetic factors, there's hormones that are in the body that cause you to eat more once you lose weight. There are just so many factors here that it's impossible not to call this a chronic disease, because the definition of a chronic disease is that it lasts over a year and affects your health. And we know that obesity affects so many other things. The reason I enjoy treating obesity is because I know it'll help prevent things like diabetes and blood pressure and cholesterol, heart disease, and even some cancers. It can help prevent cancers. So weight loss is very important, but obesity is a chronic disease because it lasts so long and it causes so many health issues for people.
It's such an important concept for everyone here to understand that if you go to the doctor and you're looking for help with your weight, and the answer is you just simply need to eat less and move more, that we as patients should not accept that answer. And in fact, that answer that is often given really lends itself to the bias and the stigma that we experience, because it's such a simple formula. And why can't I just get it? Understanding this, what is the role of diet and exercise in obesity management?
Well, I think that both do play a role. Certainly, if you are able to eat fewer calories and burn more. Of course, that only helps everything, but it's not, it's just a part of the equation. You have to make sure that you get enough sleep or good quality sleep. You have to make sure that your stress levels are controlled. If your stress is super high, it's very hard to lose weight. There's different kinds of exercise. There's also activity. You need to break up your sitting in the day. And a lot of us have realized during COVID that that is especially true. Weight gain has been rampant during COVID. And so, yes, exercise and diet play a role, but they are just two pieces of a very big puzzle.
Yeah, well, you mentioned that, the puzzle, and we know that the clinic practice guidelines came out in 2020, and they talk about 3 pillars of treatment for obesity. Can you explain what these pillars are?
Yeah, so the Canadian practice guidelines, the obesity practice guidelines from in Canada, are just some of the best guidelines published in the world. They're being used by a lot of different countries that are using them or modifying them for themselves. They are just so comprehensive, and I like the way that they framed a lot of things. So the three big pillars that they talk about in these guidelines are basically you've got exercise, you've got activity, and then you've got the psychological piece. And that is a huge piece. I think that might be the most underrated piece of the 3 pillars. If you, and I like what they don't just call it nutrition or diet, they call it medical nutrition therapy. I think that's a very good way of framing it. We need to look at, there's different kinds of foods. In the end, it doesn't matter what kind of diet you go on. They all lead to the same amount of weight loss, but you want to also eat foods that are healthy for you. You want to have a healthy relationship with food. The physical activity side, there's, like we talked about, there's activity throughout the day, and then there's exercise, and they play different roles. But the psychology piece is the one that I think is the most overlooked as one of the pillars. And there are so many psychological reasons that we eat. We don't just eat because we're hungry. We eat for social reasons. We eat to celebrate. We eat when we're bored. And sometimes we're passed on unhealthy eating habits or an unhealthy relationship with food. And so that's where the psychological piece can really help.
And when we're talking about the pillars, what role do anti-obesity drugs play, and what role would bariatric surgery play?
Yeah, so the 3 pillars are the foundations, but then the add-ons, if you will, are medications, and there's we can go into them in a bit, but also bariatric surgery. And people will often ask which one is the right one, and there's different ways of looking at that, but it comes down to what the patient wants, actually. I think the 3 pillars have to be there, and then it's a matter of what else you would like to add on, which would be including medicine and or surgery.
And in fact, some people may need all 3 pillars. Everybody's journey is quite different. But it almost seems like the lifestyle, not the lifestyle, but the behavioral modification, the eating, the exercise should be at the base when approaching those 3 pillars, and then you add on as needed for the patient.
That's right.
So we are going to get into anti-obesity drugs a little bit later in the conversation. So it's over to you, Rachel.
Thanks, Sandra. Anil, obesity treatment is of great interest to our community as we all look to figure out the right ways for us to manage our weight. But many of us in this community have not really received the best care from, our physicians and our care teams. As a physician yourself, how do you determine what is the best course of action for a patient that's looking to manage their weight or deal with the disease of obesity?
Well, I think you start off with it has to be you should join a program that does this or a method of weight loss that is a sustainable long-term method. Let's start off with that. I really discourage people from joining any kind of program that promises you 20 pounds of weight loss in 20 days or in a month or whatever it might be. First of all, the body is incredibly complex. Everybody's reason for weight is different. Some people it's more genetic, some people it's more environment, some people it's stress, etc. So how can any one program promise you that they can help you lose 20 pounds in 1 month? That's a warning sign to me right off the bat. to find the right care, you need to go with somebody who will customize a program for you and really go through your history thoroughly, discuss all the options with you, and based on your life, based on your other conditions. So there are medications, for example, that may be leading to weight gain. And so the person that's treating you should be able to look at that and say, well, is there room for changes here? There's not always room, but it's something that they should be aware of and discuss with your physicians. You need to also make sure that it's a program where there's good follow-up, because the psychological techniques, especially, that are needed for weight loss or the change in behavior takes a while and a lot of work. And so follow-up is very important. And then, of course, any other conditions that you have. So there's something called the Edmonton Obesity Staging System, which is basically, how is your weight affecting you? So if somebody is really affected by their weight, for example, they're not able to do much, or they have diabetes, blood pressure, cholesterol, a lot of different issues, arthritis in the knees, lower back pain. These are all reasons to maybe bring up the topic of a weight loss surgery or medicine sooner rather than later. So the later you are in this scale, the more important it is to talk about all the options. However, I do like to, and I think every provider should bring up every option for the patients and go through them, discuss the pros and cons. Not everybody's going to be open to surgery. Not everybody's going to be open to medication, but you should at least be aware of them. And the provider that you go to should be able to have a discussion with you about all of these things. That is so important.
Yeah, totally. And I get it's, I even just scrolling through my own social media, get these ads about these quick fixes. And sometimes if you're feeling in a bit of a desperate place, like you're at that end of the scale you talked about, where you're feeling like there's a lot of things in your life that are maybe being affected by your weight, you can easily jump onto those things, but it really does have to be something that you look towards as a long-term solution, because this is a complex disease.
Exactly.
So speaking of that, we talked about one of the options being pharmacotherapy. And right now we have 3 medications on the market, I believe, correct me if I'm wrong, but Xenical, Contrave, and Saxenda in Canada, at least.
Yes.
What else is coming? Well, first of all, yeah, are those the right 3? Is that all that we have? And what else is in the works for Canada?
Yeah, so, and you're right in that those are the 3 that are approved by Health Canada for weight loss currently. In the States, there are a couple more options, but in Canada, these are the 3. There will be others coming up, but let's talk about these 3. Let's start with these 3. One of them has been out since 1999, and it's called Xenical. And you would have thought that if it was highly successful, a lot more people would have been on it. The problem with that, or the challenge with that medication, is the side effects. They can be quite bad, severe diarrhea to the point where people can't make it to the washroom. So I don't tend to recommend that one. However, again, it's all up to the patient. I do inform them of their choices. And some people have used it before with success. It is a fat blocker, so it blocks 30% of the fat that you're eating. So you don't absorb 30% of the fat that you're consuming. And so lower calories in. But because of those side effects, most people don't opt for it. Some people have lost successfully in the past on this medication and would like to go on it. And so as long as they're aware of the side effects, I'm okay with prescribing it. The other medications have come out more recently. So, and they, in my opinion anyway, hold a lot more promise. So one of them is Contrave. And Contrave is a combination of 2 other medications that have been on the market for years and years and years. One's called Wellbutrin and one's called naltrexone. They both kind of help with the cravings pathway in the brain. So for people that have very strong, their main issue, and perhaps their only issue, but certainly their main issue, is cravings, where they have uncontrollable cravings for food, this is a medication that can often help. And it comes in a pill format. You got to take it twice a day, but it does help a lot with cravings. 5 to 10% weight loss, which is what you see with most of the agents. And then the last agent is something called Saxenda. And now Saxenda is a very interesting one because it's actually an injectable medication that you give to yourself every day. easy to do. It comes in a pen. I haven't had anybody have problems with it, but it is, what it does is it slows down the food going through your gut, and then it also sends a signal to the brain telling you that you're full. And this kind of works around the clock, so to speak, rather than just with cravings. So your meal sizes, in general, I find people will say their meal sizes are smaller, they have less desire to snack between meals, and often even the nighttime cravings are controlled as well. So these are three great choices. Well, I think two great choices, and one if somebody really wants to do it. But the exciting part is that I think we're in the infancy of these medications. There's a whole bunch of new ones coming out. For example, in the United States, there's already one called Wegovy. Wegovy is similar to Saxenda in that it's an injectable, but it has led to in the studies anyway, it has led to the most weight loss that we've seen with medications, which is about 17% on average on the people that are able to kind of take it up to the highest dose. It does have side effects and work through the side effects. 17% is very impressive. That's the level of some surgical procedures for weight loss, some of the smaller ones. So I think that when that gets approved in Canada, and it's probably in the next few months is what we're guessing, that's going to be another game changer, and it'll take Saxenda and the current medications to the next level. I'm really looking forward to being able to help people with that one. And then further down the line, we have even more things that are being studied. They're all studying basically the hormones that are from the gut that go up to the brain and tell you that you're full. These hormones, we know after a bariatric procedure or a weight loss surgery, what happens is that these hormones that cause you to feel full, the levels go way up and work on the brain, and so your appetite actually decreases. So it's not just that you're constricting the size of the actual gut, it's that you're actually changing the hormone levels in the body. So now the medical side is getting to the same point, and they're discovering how to increase these hormones with medications rather than surgery. So you'll see in the next 5 to 10 years, there's going to be a lot of agents out there. It's going to be fantastic.
It's an exciting place to be.
It really is. I think, it's I've been wanting to do this for 20 years. I did it in the United States. I practiced in the States for 9 years, many years ago. We just didn't have great medications. I didn't feel like I was really helping people. So I went back to family practice. And then even here, I've been in Canada for 12 years. It's only the last 2 years when I realized that there's these new medications available that I thought, now I feel I can truly help people from the medical side.
So before we go into the next question, you've touched on surgical solutions a couple of times. Do you mind sharing what those are?
Yeah, so you've got several procedures. One of the most extensive ones is called the common name for it is the gastric bypass, but the Roux-en-Y procedure, where they basically take out part of the stomach and reattach it to a different part of your intestine. So you bypass quite a bit of the gastric tract. So basically you have less room for food to go to. The hormone levels change. But with that, as you can imagine, when you change the gut that much, you do have issues with what we call malabsorption. So you don't absorb the vitamins and everything as well as you should. And so these procedures are major procedures. They are very effective for sure. They can lead to 30% weight loss and more. But they should be approached with, you should know a lot about them, and you should know what you're getting yourself into. Once you have the procedure, you need to take vitamins for life, etc. There are other procedures like the sleeve gastrectomy that is more minor, does lead to fewer side effects, but also to less weight loss. There are other procedures like a gastric balloon and other ones that are approved that lead to even less weight loss. So there are several procedures out there, and they're not all equally. I know in some people's minds, these can almost be viewed as dangerous. I don't think they're dangerous, but they are major surgeries, and some are more major than others. So it's important to understand them fully know that they're not necessarily a permanent solution as well. You still need to make lifestyle modifications. Working through the psychological piece is very important. As we've talked about from the beginning today, obesity is a very complex disease. There is no quick fix. Even surgery is not a quick fix. A lot of people do end up regaining their weight. So you want to certainly tackle the psychological side. And I know that now they're even doing research with doing the surgery and then doing the medicine immediately afterwards to kind of make sure that you keep the weight off. So again, exciting times. We're seeing a lot of different things coming down the road, which is great.
Yeah. And maybe we can talk about what one of the key challenges is. I think even with these 3 medications on the Canadian market right now, they're pretty expensive. And, with this new drug that's coming, which really could be a game changer for us, we're really struggling with coverage. Is that going to be something that possibly will be covered with, just your provincial health plans, or if you have a private health coverage package? So how effective will it be, even when we have those game-changing drugs? How effective will it be if it's not accessible to the people that need it?
Yeah, I think that's what's the main factor that's going to limit us. I think if there's not coverage for the medications, only select people are going to be able to take them. And it really highlights the inequalities or the inequities that we see in healthcare. These medicines should be available to all people, just like blood pressure medications are and cholesterol medications are. They should be covered by plans. They should be covered by provincial or state plans in the United States. They should, because they're preventing, in my opinion, they are sometimes treating diseases, other chronic diseases besides obesity, the secondary diseases such as blood pressure, cholesterol, diabetes, fatty liver, the list goes on and on. But in some cases, they're preventing those diseases. So you may be preventing other medications from being used in the future. So I do think that we are going to need coverage for this to make a huge impact on society. Thanks to the work that Obesity Matters does and other organizations are doing, hopefully we will be able to advocate and get this coverage.
Yeah, I mean, that takes me to my last question, actually, around advocacy, because I think that is the key to making something like this happen. How can we collectively advocate for better access, better treatment, and more accessible solutions?
Yeah, I think one of the best ways is to actually join an organization like Obesity Matters, because they are advocating for everyone. And so the more members there are, the more helpful it is. You can even write letters to senators and people and politicians and things. You can write letters to your health plans, to talk to HR people if you're working at a company that doesn't have coverage. And the more awareness we create, the more likely we are to get somewhere with this. There really is strength in numbers. If nobody's talking about it, nothing's going to change. So the more you can discuss this with key decision makers and also join organizations that are doing this, I think that's what's really going to make a difference in the long run.
Absolutely. So the floor is now open for questions. We will alternate between live questions, which we definitely prefer, and ones in the chat box in order of relevance. We encourage you to turn on your camera when you're ready to ask a question and let us know where you're tuning in from. You can also raise your hand virtually on Zoom. And if that's really difficult, you can wave your hands and I'm sure someone will see you and will ensure that you get to ask your question. So I'm taking a look around. I don't see any hands raised at the moment. If you're still thinking about what your question's going to be, do so. Maybe we can check in with Rosie in the chat box, because I see that it's really been on fire since we've been chatting, Anil.
Wow. Okay.
Rosie?
Great, thank you. We have a question around clinical trials. Are you aware of any clinical trials going on in Canada for new medications?
In Canada, I can't say that I am aware of any particular ones that are going on here. I know that the ones that are working on these incretins, or these hormones that are secreted from the gut, those trials are mostly based in the US. We probably have some sites here, but not that I'm aware of, unfortunately. And like I said, Wegovy, which one of the medicines, the trials are already over. We're just waiting for approval for that one. So the trials would be more for the next generation of medications that will be coming in, hopefully the next few years.
We do have a hand raised. Shirley, would you like to unmute yourself? Tell us where you're tuning in from, and the floor is yours.
Hi, I'm Shirley, and I'm from Winnipeg, Canada. And I guess my question is, I've probably been on some kind of diet for most of my adult life, and I've yo-yoed up and down at least 50 to 75 pounds about 4 or 5 times. I probably don't qualify for any of the drugs because my BMI isn't high enough, but I struggle with my weight. What are the options for, because I think all the drugs at this point anyways are based on BMI, and you have to be a certain BMI to be subscribed them. What are some helpful hints, or what do we do? And does yo-yo dieting make matters harder and worse as time goes on?
Yeah, great question. So let's start with BMI. So BMI, you're correct in that usually the Canadian practice guidelines, the obesity practice guidelines for Canada, do say that medications should be used in people who have a BMI of over 30 or a BMI of over 27, but with other conditions. So other conditions is a very long list. So if you fatty liver would be on there, high blood pressure, high cholesterol, diabetes or pre-diabetes. The list, there's many other things, even arthritis, really, if you've got severe arthritis of the knees, that can be considered a coexisting condition that's made worse by the weight. So you can get medications with a BMI of 27 and over with these conditions. The issue with BMI is it's not the absolute best way of deciding somebody's health risks. Probably the better way actually is waist circumference. And so if somebody, because the reason for that is that we know that the central weight, or the central obesity, so weight stored in your midsection, in your abdomen, is not just a storage of calories. It's actually metabolically active tissue. So it's secreting hormones that increase your odds of diabetes and blood pressure and heart disease and all of those things. And so the best measure of how much weight you have centrally is the waist circumference. So some doctors may look at that and say that would qualify you for medications as well. And sometimes we do have to write letters to the benefits plans to try to get that coverage. As far as your questions about the weight loss, the yo-yoing basically, yeah, you're right in that yo-yoing does, weight gain, weight loss, weight gain does tend to change the metabolism a bit. One of the best studies that I've seen is there used to be that show, The Biggest Loser, years ago. And they actually followed a group of participants who had lost a lot of weight, and they wanted to see what happens to them years later, what happens to specifically the metabolism. And so what happens is when you are at a high weight, your metabolism is actually higher when you're at a higher weight, because your body has to do more work kind of moving you around. When you lose weight, your metabolism drops. So as you would expect, the participants, because they were in such an intensive program, when they go back to normal life, can't maintain that program, they regain weight. You would expect that their metabolism then comes back up. Unfortunately, that's not what they saw. The metabolism lagged behind the weight. What we don't have the answers for is how long it lags and how long it affects you. So basically, you regain the weight, but your metabolism is still down here. So it makes it easier for more weight gain. And so that's the reason that, yeah, we do encourage weight loss that is sustainable, something that you can see yourself doing for the next 10, 20, 30, 40 years, rather than just a diet that most of us, we kind of know from experience. After a few months to a year, maybe a couple of years, it gets very hard to hold on to that diet. Does that answer your question? Yeah. Okay. All right.
Thanks, Shirley. Yeah, that's such a great reason not to jump into those like fast diets. Yeah, it's not a good solution for many different reasons.
I've seen so many patients that have lost 100 pounds on one of these commercial programs, and they gain it back, and then years later they want to do it again. And I think we all have this feeling like this time I can do it. But when you look at the program, without naming it, it's a very restrictive program, and it doesn't make sense. It makes sense in the moment. Yes, you will lose weight, but are you going to be able to maintain that weight loss? And that's what's super important, I think. And
Absolutely.
I think everybody that's probably on here probably has tried a diet and may have regained weight as well. So I know everybody kind of knows what I'm talking about.
Oh, 100%. I get it too, as a previous yo-yo dieter myself. Rosie, over to you. Are there other questions popping up in the chat box?
Yes, absolutely. And on this theme of dieting and looking at our lifestyle, what we can do to try to manage weight, we have a question about seeking your opinion on intermittent fasting.
Mm-hmm. So I think that intermittent fasting, like every other plan, I think is good if it works for you, basically. There's no diet plan that works for everybody. Let's start with that. And anybody who tells you that their diet plan works for everybody is not really looking at the data. Every single diet has people that it just doesn't work for. So the key to picking something is picking, if we're going to call it a diet or a lifestyle, picking something that works for you. So for some people, I do have people that intermittent fasting does work very well for, and it's kind of been their lifestyle all their lives. They don't eat breakfast. They kind of concentrate their food at the end of the day. But then they learned also that you can eat way too many calories in one part of the day, so that they have adapted it so that they eat less during that one period, but it works for them and it works in their lifestyle. You have to feel pressured to, there is no one diet that's going to work for you. Let's put it that way. If it sounds like it's something that you can do long-term, that's worth trying. If you think, I can do this until I lose X number of pounds and then I can go back to my normal eating, that's probably not the plan for you, because the weight's probably going to come back at that point. So I don't think there's anything magical about intermittent fasting. I do think it works for some people. I also know a lot of people that do lose weight on it, but then regain weight because they're not maintaining the intermittent fasting. So the key is this something that you can do long-term? If you approach everything with that in mind, then you're less likely to have the yo-yoing.
Yeah, absolutely. I agree. Every time I think about some changes that I want to make for myself, can I do this forever? Will this stick?
Right. Yeah, absolutely.
Yeah. I don't see any raised hands, but I definitely encourage people. Oh, wait, we have Virginia with your hand raised. If you'd like to unmute yourself, Virginia, and ask your question.
Good morning. I'm Virginia from Flin Flon. Where I live, I'm 8 hours away from Winnipeg, for example. And so we only have GPs basically up here, or nurse practitioners. For any of the medications that you talk about for weight loss, is it better to be referred to a weight loss bariatric clinic to be followed up, or are GPs a good source to follow up? And yeah, I guess that's basically what my question is, because I kind of wish I lived closer to a bigger center that I could take advantage of
Right.
the weight loss clinics to have a referral to people specializing in that area.
So a couple of suggestions I would have is the answer to your question about whether you should seek care with your family doctor or with a specialist is like the answer that I'm going to give to a lot of questions. It depends. Some family doctors are very comfortable with these medications and are able to give you perhaps even more support than you would get at some of these other programs. So it all depends on your provider. I know that more and more providers are certainly getting comfortable with these medications and with the concept, let's be honest, with the concept that obesity is a disease that needs to be treated for people that are seeking care. If it's impacting your life and you're seeking care, then we should be helping you. And there's less and less physicians, I believe, that are saying just exercise more and eat less. However, if your family doctor is saying that, or your provider is saying that, a couple of thoughts I have. One is I think you should, speaking of advocacy, one good idea might be to print out the Canadian obesity practice guidelines and actually send them to his office and say, this is what I'm interested in. This obesity is recognized as a disease by the Canadian authorities, all the Canadian medical organizations, the American organizations, the World Health Organization. I need help with this. Are you able to look through these guidelines, and would you be willing to help me? Sometimes just the education piece can help. Of course, do it in a nice way, in a kind way, but and if that still doesn't work, then you could ask for a referral to a specialty center. The good news with the specialty centers, they're not even necessarily you have to go to a specialty center, but a weight loss physician that also has dietetic services that might help you. A lot of them are being done virtually now, so it almost doesn't matter where you live. I know that I see a lot of my patients, I'd say 90% of my visits are virtual nowadays. That's one thing we've definitely learned during COVID. And for weight loss, because a lot of the stuff that we're talking about during the visits is more about the psychological principles, the medication side effects. And this is one thing I didn't bring up earlier that's very important, is it's not always just about the number on the scale. There's so much more. How do you feel? That's one of the major questions. How are various parameters doing? So how's your sugar? How's your blood pressure? How are all these other things doing? So this can all be done virtually. We can send requisitions to you to get blood work done. There are probably pharmacies available where you can take your blood pressure, so people self-report their blood pressure to me. There's very little that I actually need to do in the office. So, and I know that a lot of doctors are operating that way. So you could find someone that you could be referred to that does work virtually. So that would be another solution.
Thank you.
Yeah, no problems.
Thanks, Virginia. And I really like your background. I'm so glad you mentioned, Anil, the option to go virtual. I'm currently in a very remote and rural area of Newfoundland, and I'm so thankful that I can still see, my doctors, even those doctors back in Ontario, virtually. So I think that if, of all of the bad things that are happening because of the pandemic, there are also a few good things that we're getting better at virtual care, I believe.
Yes, absolutely. You are correct about that. Yeah.
I see that, Kathleen, you also have your hand up. Would you like to unmute yourself? Tell us where you're tuning in from, and the floor is yours.
Hi, good morning. I'm Kathleen from Edmonton, close to Edmonton, Alberta. And I think you just kind of touched on my question, actually segued into my question. I wanted to go back to the psychological pillar and knowing that, behavior change, it's a big influence in what I'm trying to do, and it's definitely long term. And I'm wondering if you could comment on, are you thinking of is this group therapy? Are you talking about individual counseling? And again, I guess I hadn't really thought about that virtual option. Any ideas on how to access some of that we have a family doctor, of course, but how do you access anybody else on a team? I don't feel like I have a team or even know how to get one.
So in terms of, thank you for your question, Kathleen. In terms of how you can reach out to some of these places that are, you can take a look at a few things. There's, let's see, one of my recommendations is the American Board of Obesity Medicine. If you were to look at that, they would have they have a way to search in your area for people that have that qualification. I think that qualification is very important because that, you know, that if a doctor has gotten that board certification, they truly understand this disease and are more likely to be able to help you. There are people that don't have the certification that are very good, but how do you tell is the big question. And so looking there is a good way of finding someone. Now, sometimes they will require a referral from your family doctor. What would make it easier is if you had a name and all the contact information and everything to provide your family doctor with, then he or she should be able to make that referral for you. In terms of counseling, yeah, it can come in a variety of ways. So family doctors can often provide the counseling. I think group sessions are very good as well. These some of these programs actually have psychologists in them. Now, of course, when you add on psychologists, you add on dietitians and all that. A lot of that is not necessarily covered, and so it depends on benefits and it depends on cost of the program and all that. But there are definitely programs that have full coverage, might not be as comprehensive, but the counseling can be done from a variety. There's even, I work with a dietitian who's has a lot of extra training in the psychological principles. So she does a lot of the counseling. And so there's a variety of ways to get that counseling is, I guess, my point.
Yeah, I think I just noticed that in the chat box, we've indicated some places where you can go for a clinic locator, and that will also probably be attached to our show notes today. So thanks for the question, Kathleen. Back to you, Rosie. What's happening in the chat box?
Great, thank you, Rachel. We have a question on how you would counsel patients interested in medications, and when you face questions on whether the medication is working. How do you help patients get on a path where medications are supporting their journey?
So yeah, there's because we have these several agents, it all depends on choice in terms of preferences in terms of pills versus needles. We like our initial assessment, any initial assessment should be very thorough and talk about all the potential side effects and everything. So a lot of times with these all of the weight loss drugs have to be titrated up slowly because they do have a fair share of side effects. The main side effects that I see are mostly to do with the GI system. So gastrointestinal, nausea, vomiting, diarrhea, constipation, and reflux tend to be the biggest side effects. And so it's very important to titrate these medications slowly to the point where your side effects are gone, and then you can move up to the next level and so on, rather than if your provider is not asking you the questions about how are your side effects, then you want to make sure that you let them know that, you know what, I still have nausea. You don't want to change the dosage. You don't want to increase your dosage until that's gone. So it's very important to do things slowly. And then the other thing that people don't talk about is what if it's not working? Well, then there's a matter of titrating it down and trying a different agent. And also people talk about, well, now I've lost 30 pounds, I've lost 50 pounds. Now, again, these medications there is no magic bullet. They, in general, lead to an average of 5 to 10% weight loss. But if you're able to layer on other lifestyle changes, you're able to work on some of the psychological issues, and you can see more weight loss for sure. But let's say you get to a point where you're thinking, okay, I plateaued, and is it time to change the medication? Well, one of the things we like to tell people right off the bat with medications is we have to think of these medications in the same way that we think of medications for diabetes or blood pressure or cholesterol. I would not put you on a diabetes medication, and if your sugars were now well controlled, I wouldn't just stop the diabetes medication, because we know the blood sugars will come up. And oftentimes with these weight loss medications, it's the same thing. If we stop the medication suddenly, your hunger will come back at a level that will quickly get you back to the weight you were at. And so if you feel like, I think I've made enough lifestyle changes, and you wanted to talk to the doctor about coming off of the medication, I would have the discussion and titrate down very slowly, see how you do. If you're able to maintain the weight loss, we want to keep you on the lowest dose possible. And if you're able to maintain, we keep going down. If we're able to take off the medications, that's fantastic. But if we're not, it's not a failure. I want to make sure that's clear. I don't want people to think that you failed if you need to be on a medication for life, because if you have blood pressure and you're on a medication for life, you wouldn't consider yourself a failure, and nobody else would. And it should be the same with these medications. They are attacking a biological process, these hormones that cause hunger. They're supporting your lifestyle changes. So, for example, if you lose 10% of your weight, oftentimes, I did see in the chat box, people talk about sometimes you're very limited by knee pain or back pain, but the medications will often help you lose the 5 to 10% that will make those issues better, or better enough where you're now able to do more things in your lifestyle. You're able to go for walks, you're able to do more physical activity. I usually don't like anecdotes, but I'll give one. I had a patient who was 65 years old at the time, and that I started on one of these medications because he couldn't walk to his mailbox without getting winded. And he said, enough is enough, I need to do something. And so we started him on medication, and he wanted to walk, but he couldn't. Once he lost 5 to 10%, he could breathe a little bit better, his knees hurt a little bit less. He started walking, and long story short, over the course of a year, he lost a significant amount of weight, I'd say about 40 plus pounds. His numbers, not just on the scale, but his sugar, his blood pressure, everything looked so much better. And importantly, he felt better. He felt much better. So sometimes these medications are just a start to lifestyle changes, and plateaus are to be expected at some point. That doesn't necessarily mean you have to come off of the medication. You can even add on a second one if there's still things impacting your health.
Thank you. I think we have time for maybe one more question from the chat box, Rosie. And then, of course, if someone wants to raise their hand, if they've got a burning question, we'll try to fit that in as well. So Rosie, over to you in the chat box.
I think Rosie's internet is active.
Oh.
So there's a comment that I just want to bring up, and probably Anil can speak a little bit to that. Maura says the word pain is seldom addressed, such as joint pain and lack of mobility due to pain. And I know a lot of sort of patients, so to speak, or people living with excess weight have this problem. So we'd love for you to talk a little bit about that.
Yeah, that was kind of the point I was making with the last question, is that I think there's a lot of people that do start off, like that gentleman I just was talking about, that do start off with not being able to do much physically. As a matter of fact, in the Cleveland Clinic program that I'm involved with, we don't talk about exercise for the first month or two, because unless the patient wants to, because some people are in pain and they just can't. And so we work on the other strategies first, help you lose some weight that then takes the strain off of those joints or the lower back, allows you to move a little bit better. And there are certain people, unfortunately, that due to other medical conditions, the pain doesn't get better. And then we do the best that we can with the other techniques. The good news, the more pieces we're able to put into place, usually the better the weight loss. But we do know that the exercise piece is not as efficient at weight loss as, let's say, the eating piece, the nutritional piece, and the psychological piece. And what the psychological piece really helps is with the eating piece. And so most of the weight loss comes from changing how we eat and our relationship with food. Exercise is definitely good for our health and can help increase weight loss, but it's not the primary focus. It is one of the pieces to the puzzle. We hope that with a little bit of weight loss, we can get those joint pains and back pain improved enough so that you're able to do more. And then as you do more, the pain tends to improve as well, because your muscles are in better shape and support the joints as well. So it can be a very positive cycle that way.
Wonderful. Thank you. Time for one more. Priti, is there another burning question in the chat box?
Yes, there's one from Mena, which I think was missed. Can you please comment on when people say the medication stopped working for them? Please comment on, now I'm not sure if I'm saying this right, tachyphylaxis with GLP versus Contrave, for example?
Right. So tachyphylaxis is a side effect of like a very rapid heart rate. One of the side effects of the GLP-1 agonist, which Saxenda belongs to, and that new medication called Wegovy in the United States belong to, is that they can raise your heart rate. On average, it's only a few beats per minute, 2 to 3, I believe the studies say, but there are some people that have their heart rate raised a lot more, and then that might be a reason to stop the medication. With Contrave, we can see a little bit of heart rate gain as well, but the bigger issue with Contrave is we worry about the blood pressure. It can raise your blood pressure. There are other things, of course, if you have a history of seizures, this might not be the right medication for you. But in terms of heart rate and blood pressure, Contrave, we worry more about blood pressure, and we worry more about heart rate with the GLP-1s. So again, these medicines have to be tailored to you and to your side effects and what other medications you're on as well.
Absolutely. I see that Rachel raised her hand. I missed that one last time. So Rachel, if you'd like to unmute yourself and tell us where you're tuning in from and what your question is.
Great, thanks so much. I'm Rochelle Hanson. I'm calling from Toronto. I'm in Toronto, downtown right now. So interesting about the medicine. So the last medicine I tried successfully, which I loved, was fen-phen, which we know killed people.
Right.
And so ended up off the market. So of these, and I haven't been on anything then for the last 25 years or whatever. I am part of the Humber River program. I've lost 55 pounds so far.
Fantastic.
Cindy's comment, you absolutely terrified me because I'm every day exercising because I'm terrified of losing or gaining this weight back. But my question goes back to the drugs, because this is clearly a holistic thing. So when you look at what's on the market, then like what is something that's comparable to the fen-phen? Like I just felt the energy level was good. I was very active. I just felt amazing on that. So I'm just curious what your
so
it killed people, but I felt great.
Yeah, the reason you felt great is because it's an amphetamine.
I didn't know that.
Yeah, so it does. It's interesting that it is. So fen-phen is a combination of fenfluramine and phentermine. Phentermine is still approved in the United States. Fenfluramine was the part that caused all the heart issues. And so that they withdrew from the market. So phentermine is available in the States, and people do say that they feel more energy with it and things like that. We do not have a comparable product here. For people that have binge eating disorder, there's a medication called Vyvanse, which is indicated for that. And it is a stimulant as well. It's used for attention deficit disorder. And I've heard of similar feelings with that, but I wouldn't recommend it to everybody. I think if you had issues with binge eating specifically, that might be something to talk to the doctors about. But I think that the best products we have right now are the GLP-1s, and then Contrave is another product, but they do not cause that high energy level that you're talking about.
Okay, too bad. No, I was at the gym every morning at 6 o'clock. I was like, woo, let's go.
Yeah, not that level. Some people, obviously, as you lose weight, you do feel more energy and things like that, but not the level you're talking about.
No, okay. All right. Thank you for that. Thank you.
Welcome.
Well, thank you, Rochelle, and thank you, everyone, for your wonderful questions today. Apologies we didn't get to everything. And Anil, we'd like to thank you for so generously giving of your time today. I'd say my biggest takeaway is something probably that emphasizes what I already know. Obesity is a chronic complex disease, and the solution can also be very complicated to that. So we've got to look for things that, we are going to do for the rest of our lives, and sustainable long-term solutions.
That's right.
Well, I'd like to say to our audience to get involved as a member of the Obesity Matters community. We will be sending out a survey and would appreciate you completing it so we can continue to build programs that are recommended by you, our community. Be sure to tune into our next session next Wednesday, December 1st at noon Eastern, the impact of weight stigma on public health. And wear your favorite ugly sweater. Until then, enjoy the rest of your day, week, and we'll see you soon.
Bye, everyone.
Bye.